Thank you so much, and very welcome to you all. And I think today we have at least people from Estonia, Bulgaria, Romania, UK, France, yes, a lot of countries. So please feel extra welcome to Stockholm. And I couldn't fix the weather, I'm very sorry. It's too cold for me, as a Swede as well. Vi ska börja med att få lyssna till en person som har väldigt många olika roller i Europa. Och inte minst så är hon ordförande för IAPO, International Alliance of Patient Organizations. Det är ju faktiskt så att det finns internationella patientorganisationer på alltså den högsta globala nivån som förhandlar och pratar med FN, WHO och så vidare. Och vi tänker från FOKUS Patients sida att det är väldigt intressant att också få ta den högsta nivån tillsammans med alla lokala, regionala och nationella organisationer och se faktiskt att det finns en röd tråd däremellan. Och vi ska snart alltså få lyssna till Dr. Neda Milevska Kostova. Och jag är jätteglad över att hon kan delta digitalt idag. I will soon introduce Neda Milevska Kostova, who is one of the most experienced in healthcare. And not the least, today she is entering the stage digitally to present her organization as a president of IAPO, International Alliance of Patient Organizations. And I know, Neda, that you were at the UN meeting last week and also present patients' view in that kind of surroundings. And you are so welcome to FOKUS Patient event today. Please, Neda, the stage is yours. Thank you.
Thank you, dear Penilla. Good morgon, but that's about all I can say in Swedish. Good morning to everyone and welcome to everyone from my behalf too. It is a greatest honor to be part of this event. We've known with Penilla each other. We worked for quite a years now, and all I can say is that FOKUS Patient is a really great initiative, something that it is at the core of all the efforts that we are having and that we are trying with IAPO, and that is to put the patients at the center. And FOKUS as a patient-led initiative is the true essence of what we would like to see in many countries and in many organizations. We didn't really talk as to whether it's appropriate to have slides or not, but in any case, I just prepared a few. Let me share them with you just to briefly guide us through what I will be saying. I'm not sure, are the slides visible? Can you see the slides? It doesn't seem like. Is it possible to see the slides? Yes? Okay. So my name is Neda Milevska Kostova. In this capacity here, I represent the International Alliance of Patient Organizations, to which I serve as a chair at the moment. The organization was established in 1999 with the vision to see the patients at the center of healthcare and to build the patient-centered healthcare worldwide. And with this, we have more than 280 members representing more than 1 million patients in 70 plus countries. And all of them work in different areas, which is more than 50 disease areas. You would understand that this is quite a scope that IAPO is covering. However, at the core of IAPO is really to see patients leading the work, patients being involved at every possible table where the healthcare and provision of care or the quality of life overall is considered or discussed. With this in mind, in 2020, IAPO established the IAPO Patient for Patient Safety Observatory exactly for this purpose, to enable patients to be more involved in this process in a structured manner that we can gather and analyze patient experience and expertise that would feed the national, regional, and global policies, and all towards improving the safety and quality of care of the patients by the patients. Well, just briefly, because I was asked to talk more about the need for the person-centered care and where to start then from the patient. Sir William Osler, more than 100 years ago, said that the good doctor is the one that treats the disease. But actually, the great doctor is the one we want, because that is the person that that is the doctor that treats the person who has the disease. And why is this relevant? You can see in this small clock below that actually the patient undergoes all of these day and night, all of these different hurdles when it comes to their health, starting from the change that they might identify. They neglect it at first, they postpone, they live with, they hesitate whether they should visit the healthcare system or not. Then they visit, there is uncertainty, multiple visits, first, second opinions, finally diagnosis being established. Then comes the realization of the realities, sometimes denial, acceptance, treatment follows, and then the follow-up of adapting to the new lifestyle, going back to normal. And the healthcare system plays a role in all of these steps, but only dismal, because the patient undergoes 24/7 all of these changes. And for this reason, the healthcare systems need to be centered around the person, because they need to take into consideration not only their medical needs, but also their social, cultural, and all kinds of needs that they have, so to enable them to be treated with dignity, respect, and compassion, and all towards achieving the better health and the quality of life. I will just give you one example, and I'm sure there are many examples of why this is relevant and important. We had one patient that we interviewed. We have many interviews and interactions in IAPO, but this one patient struck me really significantly, if you wish, because Paul was someone who had a stomach problem, ended up going to hospital and had surgery, and faced the sepsis and septic shock. But after 10 weeks in hospital, the hospital discharged him, and for them it was a solved case. Of course, he had follow-up visits to the healthcare system, but if we asked Paul about his experience, he said that his recovery was quite long. It was not only the 10 weeks in the hospital. It was followed by 3 months of recovering at home, then another 3 months for phased return to work, and then 5 years until he was able to walk properly, which means that apart from the 10 weeks that the healthcare system is viewing or seeing through their clinical or system lens, the patient is actually seeing much more and experiencing much more, something that can be prevented or some things that can be at least managed or alleviated. So in this sense, we thought that it is quite important, and talking about the second part of the task that I was given, and that is how we can do that, including methods, or how we can really try to capture the patients to be at the center, but also to share their experiences. IAPO in 2020, as I mentioned, established the IAPO Patient for Patient Safety Observatory, which of course is interested to explore the safety, but overall the quality and safety of care, and to that extent, how the patient can be put at the center. This graph is really a little bit complex, and I will not go into the details, but what it says is that by no means patients want to hijack or eliminate or minimize the efforts being done at the moment at the national, regional, or global level in terms of data collection. But what we are trying to do is we try to add another layer of the data. We try to make more meaning to the data. We try to show and we try to capture the actual issues in quality and safety, the actual prevalence and incidence in patient safety, in quality, or in integrated care. As Penilla mentioned, last week I had the honor to present at the United Nations General Assembly high-level meeting on universal health coverage that was actually co-chaired by the Swedish minister, by your Minister of Health. And she was very attentive, and she was very open to the presence of the patients, which we really felt as a great honor, but also as a big task. And during that meeting, it was one of the conclusions was that really the patients need to be part of every decision making, of every step of the care continuum, in sense of co-delivering and co-implementation, co-development, if you want, of all the solutions that actually at the end, as we all concluded also in that meeting, the healthcare systems really exist for the patients. They really exist to alleviate the suffering, to minimize it, to manage the disease that enable management, and to cure those for which there is a definite cure. So in that sense, the big step that we made last week in inserting patients at the high-level dialogue means that we at IAPO would like to hear from the patients, convey those messages up on the high-level meetings, and then convey the messages back to the constituencies where you as national patient organizations or acting locally, regionally, nationally, in whichever scope, you can then find the right tools and know the right global health agenda issues for which we can advocate among our policymakers and among other stakeholders. My slide's not moving. Yeah, well, I think maybe I can skip this slide because this is just to illustrate to you from a perspective that I bear mostly, and that is antimicrobial resistance. This is just to illustrate how we can see the different sides of the coin, meaning there is a clinical side in which you can see number of papers describing how many studies, how many number of patients, what are the percentages, confidence intervals, and so on, especially, for example, on antibiotic prescribing in this case, or bacterial co-infection. This is a case from COVID, and what those surmountable or what those big numbers mean in the sense of a bigger quantitative analysis. However, there is another side of that coin where if we ask the patients, we can see that there is a different social side, not only of medicine, but also of the healthcare system. And this is something, when we put them side by side, we can actually only then see the real value of any policy or of any outcome that we would like to expect to see. In this respect, and going back to the methods that Penilla mentioned, we try to develop a matrix that actually tries to capture what are the actually essential roles of patients in this process. And you can see there are 6. Of course, these are not exhaustive. Probably there are other new ones. These are bigger oversight roles that we discovered. And of course, patients are invited as research participants, sometimes inside providers through focus groups or interviews, sometimes as advisors on what are the outcomes of any specific research. So to check and to see whether those are really fine-tuned. However, we still feel at IAPO that there is a substantial lack of patient-led research, and especially in the lower 3 roles that are described in this graph. And those are to be reviewers, to really be those at the core who will see what is relevant, how this fits into how the data, how the interpreted data fits into what patients really need. So linking the patient's experience or providing review from a patient lens. Then be co-designer, because not every research is relevant to patients. Sometimes patients need a different type of approach, and this is very important to be captured. And finally, to be a driving force, meaning those that can be equipped with good tools, of course, data as well, to be able to collaborate, to influence policy making and implementation. I think one of the important aspects of what is happening today in Stockholm, and I'm very, very sorry that I cannot be there in person to talk to each one of you, because I think there is quite an expertise in the room today that I'm missing to capture. I think it is quite important what Mattias mentioned in the beginning, and that is to network and to exchange, because we are stronger if we stay together. I think FOKUS Patient is a exceptionally well-designed initiative, and not only as an organization, but as a movement that is trying to bring the patient voice together at the national level. IAPO is trying to do that at the global level. However, without individual organizations or even without individual patients within those organizations, we cannot bring the patient voice higher to the global agenda. In that sense, I would just like to remind you of these 3 messages that you can read without me reading them out loud, just to wish you a very successful event and to remind you once again that the patients are those for whom the healthcare systems exist, and patients are those for which we need to all try to bring as much as possible roles in which they can contribute meaningfully, not only to better systems, but above all, to better health and quality of life. Thank you so much.
Thank you so much, Neda. We really appreciate your contribution to this start of this exciting day, and wish you all success in the coming days also for you with continuing work with all the organizations you are involved in. Thank you so much. See you soon.
Thank you, Penilla. Thank you. I will stay around to listen to Frederico. Hi, Frederico.
Very good, and we just keep on, going with the international perspective, and welcome also the next speaker, Frederico, and I can probably not express your name in a proper French way. Guanais, maybe? Guanais?
It's actually Guanais, but there's a trick there. This name actually is from Portuguese origin.
Okay, so I apologize then. I would just introduce you in Swedish as well. So, Frederico, jag ska inte uttala då hans namn uppenbarligen, hans efternamn, som jag inte kan. Men han jobbar som biträdande chef för hälsodivisionen på just OECD. Så vi fortsätter med det internationella perspektivet helt enkelt. Och får också en inblick i hur man jobbar på den nivån med att faktiskt få rapporter som visar på hur man kan mäta utfall av vad patienter tycker. So back to you, Frederico, and the floor is yours, and to present your way of working with the patient-reported indicator service.
Thank you very much, Penilla. Thank you for the invitation. It's a great pleasure to be here. It was a great pleasure listening to Neda. I think it's a great tie-in. Because it was great to hear from the perspective of the patients. And I think this is exactly what the Paris survey is all about, right? To giving a voice to the people and to the patients. So I'm going to share my screen. I hope that I am going to do this right. I think that you can probably see my screen over there. Basically, what the Paris survey is about is it's measuring the experiences and outcomes of healthcare that matter most for the people. And I think this is a great alignment with what we were hearing from Neda's presentation just now. Let me just get this started. All right. So you know this, but I think it's important to have a recap, right, in the way how we measure and assess the performance of health systems. We can arguably say that the health systems assessment started by looking at deaths, mortality, and life expectancy. The data source for this comes from health registries, but over time, then the perspective started to shift more into looking at diseases, the prevalence and incidence of diseases, in addition to mortality and life expectancy data. This is something that's available on medical and clinical perspective, from administrative and clinical data, and so on. Now, moving even further, because really it's getting about not what we really want to prevent, but we want to promote, then it's the look on the disability, right? So how the health system deals with disability. And here, it's already something that's much more complex to measure because this information typically is not readily available. No, those are instruments, disability adjusted life years, quality adjusted life years, SF36. There's a bunch of letters and acronyms that capture this instruments. But those typically they could be done from registries, but most often they need to be collected through surveys. But here, when we talk about the time for a new generation of health measures, we're talking about the things that really matter most for the patients, carers, families, and population, which is well-being, function, absence of pain, quality of life. So these are the things that really we're actually aiming to collect through the Paris survey. It's important, of course, that we collect the things that we want to avoid, but really, how do we actually capture the value that health systems are giving to the life of patients and of the people they serve? But here, it's something that's much more complex because measuring healthcare from people's perspectives is not something that you can only look in the clinical records. It's not only something that you can look in the mortality statistics, for example. It requires the involvement and the perspective of various stakeholders. So I think that's very, very interesting because, we're just hearing from the International Alliance of Patient Organizations, because typically patients are the last ones to be asked and to be consulted within the health system performance assessment elements. So this is precisely what we're trying to address because this is an effort that requires involving policymakers, international organizations, industry representatives, academics, providers, and most importantly, the patients themselves. That's why we have this little sort of logo or identity of the Paris survey, which is really sort of the sound wave reverberating from the patients and into the health systems. Now, we are in this ambitious effort of the Paris survey, and what's the goal of Paris, right? Which is the acronym for Patient-Reported Indicator Survey. We want actually to work together with three groups of stakeholders, right? So for policymakers, we want to help them to make the health systems more people-centered. So by listening to the people, by collecting the data directly from the patients, then we'll have the tools and the elements that will help policymakers to assess whether they are on the right track, what kind of corrections they need, what kind of tools work better, and so on. For the patients, of course, is to make the people's voice heard. So if they're not asked, then how can we actually make sure that we have the health systems oriented toward the needs of the people? And providers as well. It's about improving the quality of care that the primary care professionals provide. So ultimately, we want to improve the health system performance through the measurement and benchmarking, focusing on the needs of the patients. So I mentioned here briefly primary care. Actually, Paris has two sides, right? Just like the city of Paris has the right bank and the left bank. Here we have the two banks of Paris. I'm going to start with the first element, with the condition-specific work. So this is a stream of work that started already in following a mandate that we received from the Ministers of Health in 2018. And the ministers that came to the OECD and said, we really want your support in helping to make health systems more people-centered. So right from the start, we started putting together an ambitious survey that was going to take a long time to develop, but we really wanted to have earlier results. And then we said, well, let's look into the areas in which there are already some development into the collection of data reported by the patients, right? So things that are associated, for example, with the patient-reported outcome measures. And then when we looked, we found there was some work in these three areas: on hip and knee replacement, on breast cancer, and on mental health. So let me start with these three conditions. Then I'll move to the second part of the Paris work, which is the survey of primary care. Right. The first example that I want to give about our work is about hip and knee replacement. Here, we worked very closely together with the national and subnational arthroplasty registries. It's always a word that I have a lot of difficulty with. But these are registries from 10 countries, from the surgeons that actually perform the hip and knee replacement surgery. So fortunately, there are some tools that have been developed, such as the Oxford Hip and Knee Score, to develop the outcomes from the perspective of patients from a surgery of hip and knee replacement. Because you might argue that from the perspective of a surgeon, if a surgeon, came into the hospital, performed the surgeon, then there was no bad outcomes. I mean, there were no infections, the surgery went well, patient left the hospital. What happened to the patient afterwards? I don't know. Well, but from the perspective of the surgeon, arguably that could be considered a success because the surgery was successful. But actually, do we know what happened to the patient 30 days after the surgery, 6 months after the surgery, 1 year after the surgery? Has the patient's mobility increased? Is the patient still feeling pain? Those are the things that also matter, and they are not captured in the hospital statistics. So luckily, a group of very entrepreneurial surgeons actually have started working together and pulling up work to measure the pre and post-operative scores using these validated scales. And then we actually have worked together with these groups in 10 countries, and we have been regularly collecting and reporting these results. Here we have the Oxford Hip Score and the Oxford Knee Score before and after the surgery. Then we see how in all countries there was improvement in the scores, saying that the patients are reported feeling less pain and being more mobile after the surgery. But we actually see some interesting things happening, that there is variation in the outcomes post-surgery, but there's also variation in what happens before the surgery. So then we can already have some hints that in some countries, maybe the process to get approval for a surgery is taking too long, and patients are actually doing that too late. Therefore, we might have poorer results. Maybe in other countries, no, the process is easier, and you actually do it in the time in which will improve the likelihood they will have better outcomes post-surgery. But I think really what I want to talk about here within this slide is the fact that this is something that has luckily become institutionalized in several countries. There are registries, there are data collections. So this is actually becoming something that's increasing over time, and then we are having more and more data about that. This is unfortunately not the case that's happening with another condition-specific work that we do, which is breast cancer outcomes. So here, if you really look closely into the slides, you'll see that sample sizes are much smaller, we have fewer countries, and so on. And these are the results of patients who live with breast cancer. And the problems that we're measuring here is reported breast satisfaction following a breast intervention. So there is some variation in the scores, and then we're happy to report those scores because we think it's important to show that, even according to the satisfaction that patients experience following different kinds of procedures. For example, a breast conserving therapy versus a reconstruction following mastectomy. So we are seeing slowly an increase in sample sizes and participation, but we're far still from observing the level of engagement and institutionalization that we have with the hip and knee score. So we would like to continue to work to see this going up. Now, another point that I think that I'd like to highlight within this line of work is that satisfaction with the outcome of the surgery is perhaps not the only outcome that matters to the patient, right? So I think it's something that we're seeing from a few countries that are actually disaggregating further the outcomes following surgery into emotional, emotional functioning, social functioning, and global health status. So here's, for example, the example of Sweden. And then we see in Swedish data, there's the post-operative score is the bar, and the pre-operative score, which is the dot. So here we see the Swedish data shows that while women report better emotional functioning 6 to 24 months after a breast intervention, they report lower social functioning and global health status. So these are the sort of insights that we think it's really important to develop, to say, well, the outcome of the patient, of the surgery, is not only whether there were no infections, whether the patient walked out of the surgery. We need to really continue to follow up and look in more detail of what's happening to the patient for what really matters to the patient. So based on this work of the condition specific, we have a few things that we have learned so far. First is that, well, increasing countries and programs show interest in the measurement and use of disease-specific PROMs. So this is remarkable, and I think we need to continue and encourage this move. However, collecting PROMs data is only the beginning. There's a need to work to continue to making PROMs actionable, right? So to improve healthcare is an important first step, but really we're collecting this data because we want action to be done. So they can be part of clinical improvement cycles, quality improvement initiatives, or they can even guide policy decisions. Third point, we can capture the perspective of the patients who use healthcare service at the hospitals. But if we really want to transform health systems, we need a broader participation, including those who are vulnerable and hard to reach. So going beyond the hospital settings is essential to capture this broader perspective. For this purpose, we think that primary care is essential, an ideal place to move forward. Fourth point, disease-specific measures provide an in-depth understanding in relation to a specific condition or disease, right? So while these disease-specific measures are helpful, further progress is needed for the collection of generic measures that are more likely to capture the overall status of the patient. Besides the physical functioning, we also want to capture global health-related quality of life, mental health, social health. I mean, the several dimensions of health according to the definition of the WHO. And last but not least, advancing the use of PROMs in transforming health systems requires policymakers' commitment, right? So systematic collection and use of PROMs data require adapted data infrastructures, adequate training of patients, healthcare professionals, and integrated into a broader agenda of quality improvement strategies. So I think all of this makes a nice tie-in to the second part of my presentation today, which is about the Paris survey. The Paris survey of people living with chronic conditions managed in primary care. So the Paris survey was the second part of fulfilling the mandate that ministers gave to us in 2017-18. Right? So right after we received that mandate, we started working with countries together to develop the instruments, the tools, the methodologies, the approach to work. Well, how do we actually have the broader approach that will not look into hospital settings only for the problems and conditions that are most important in OECD countries, well, which is the growth of chronic conditions. Then we developed this survey, and we have been working very hard over the last few years to make this a reality. I'm super pleased to report that we're finally this year in the process of data collection within 20 countries that are participating in this really people-centered approach. And we have developed 3 levels of data collection. So within these 20 countries, we're actually sampling nearly 2,000 primary care settings. in collecting data from the providers, from the characteristics of the primary care providers, and then sampling patients within the settings, nearly 150,000 patients across OECD countries, that in capturing and implementing this survey that actually collects their own outcomes and experiences of care. So we are going to actually link this 3 levels, right? Because from what we know from the system characteristics here at OECD, how is the health system structured? Is it a national health system? Is it a social insurance? How much funding goes into the system? How many doctors, nurses that we have? Well, we had all of that information already. But what we didn't have is information, for example, from the primary care providers. What are the characteristics of the settings in which people are seen? What resources do they have? What technology do they use? Is it a team-based practice? Is it a solo practice? Right? And then we're going to be linking that with the patient results themselves, right? With the things that patients report that they are getting from their treatment and from their management of primary care. So this survey is unique in its scale, structure, and the level of co-creation. So the really important thing is that for the development of that, we have a Paris patient panel with patient organizations that helped us to develop the patient questionnaire. We had engagement with the healthcare providers. We had direct engagement with WONCA, with the World Association of Family Physicians that actually contribute to the development of the provider questionnaire and the patient questionnaire as well. So this has been a process as much as we could of co-creation, working together with countries, with patients, with providers to develop these tools, this methodology, and this instrument that we hope will actually contribute to results that can have a really a big impact into improving health policy in OECD countries. So who do we ask? From the patient sides, we decided to go with patients who are 45 years or older, who live in the community, meaning not institutionalized patients, who had at least one registered contact in 6 months preceding this survey. So these are patients who are managed in primary care, who are 45 years old. This sample decision gives the advantage and the opportunity for detecting people who are likely to have one or more chronic conditions. Not necessarily, well, some of those people will report having no chronic conditions, but within this age range, the likelihood increases that people will have one or more chronic conditions. Then we're actually going to be able to compare and contrast. Are people with chronic conditions reporting better health status than people with no chronic conditions? As people age, do they continue to age well, reporting mobility, health status, well-being, or really do we see a fast deterioration in this outcome measures? From the provider side, we're collecting data from primary care providers who are licensed to serve in the general population. Of course, it varies across countries. The structure of primary care varies, but we are really looking into the providers who provide ambulatory generalist care, including chronic disease management. And the survey is also implemented with the help of the national project managers who are from each country. It's actually the counterpart that we have in each country from the government or from the National Health Institute. And then they appoint people who are experienced in conducting large-scale surveys and know the reality of the terrain and of the country where they live. So these are people who have expertise in chronic conditions and primary care systems at national level. So I already briefly mentioned about what the things we are asking, but you might want to know those in more detail. So here is just a sample of a few of the key outcomes and experiences indicators that we really, we might think that are relevant, that will shed light on some policy priorities. So for example, from the patient sides, we'll be collecting data on the general health, physical health, mental health, social functioning, and quality of life, right? So this is a broad range that encompasses the several different aspects of what's important for the patients, right? So in terms of their ability to continue to to engage in social life, in their mobility, their mental health and well-being, and their health-related quality of life. So those are broad outcome indicators, and we think, well, using the Paris data, we might be able to analyze and assess how well health systems are being able to keep people aging healthily, and as they develop chronic conditions, but if they are under control, and then people really can still continue to have good life, good quality of life, and good well-being, those are actually some of the things that are really important to us. On the other side, we have some other elements that includes, for example, the experienced quality of care, right? So some people object to that, but we think it's very important to ask the patients, how do you experience, how do you perceive the quality of care that you have received? Another important experience measure is the confidence in managing your own health, right? So we also think it's very important because if you went to a primary care consultation, receive lots of information about managing your diabetes or your chronic obstructive pulmonary disease, but you walk out of the clinic and you don't know anything, you don't remember anything, then I would say that this was actually a waste of time for the patient and for the provider. So the fact that the patients can feel that they're confident in managing their own health, it's also an indicator of experience that's very, very important to us. Trust in health systems, right? So with the Paris survey, we're asking two questions. One question about how much do you trust your primary care provider and how much do you trust your health system? And we want really to correlate that with several measures and indications that we have from the experience that people have in primary care, from what kind of symptoms they report, and from actually the trust that they have that their health system is doing a good job in keeping them healthy. We're also collecting many other data that I'm not going to comment on here, but things such as coordination of care, things such as ability, digital literacy, health literacy. So several elements that we're going to be able to compare and contrast these things with the additional data that we collect. We're also collecting data on demographics, on education, on migrant status, on income level, so on presence of risk factors, obesity, smoking, consumption of alcohol, so all of those things. And then what we really, really want is to have a comprehensive picture of who is actually being served well by the health systems, who is getting behind, what needs to be improved, right? Because what we really would want is to improve those broader and high-level outcomes that we hope are the things that really matter for the patients. So some of you may have already even heard talks about Paris, and then, you know, it's interesting because I go to conferences sometimes and people say, well, you've been talking about this Paris survey for quite a long time. When are the results going to come out? Well, I'm very pleased and very happy to report that now we are in the phase of the main survey after a long period of co-development, and that was really important that, you know, we could be doing something that was really a part of the co-creation process with the patients, with the providers, with the national authorities, and not something that just, you know, some people in Paris at the OECD would develop and come up with. But this is actually something that has been thoroughly built together with the key stakeholders that matter the most. So we did the field trial in 2021, 2022, and now we're in the field with the main survey. We already have a few countries that have actually already completed the data collection for the main survey. Most of countries are expected to complete the survey questionnaires, the data collection, by the end of this month of October. So after that, please bear with us. We're still going to need some time to clean the data, to do the first analysis. But we have a big meeting coming up in January in 2024. It's the Health Ministerial, a meeting of ministers of health of OECD countries that will come to Paris in January. Remember that I mentioned to you that we received the mandate to do this survey in 2017, when the ministers came and said, we really want more support in making health systems more people-centered. So next January, ministers are going to come and we're going to give them a sneak preview of the early results of Paris. but the real full results of Paris are only going to be available later in the year. By September, we want to hope to launch a big publication and to hold several rounds of conversations with key stakeholders, such as yourselves, who might be interested in saying, what can we learn from the results of the Paris survey? I also wanted to say that the Paris surveys are going to be made available, the data for the patients and for researchers who are going to be able to actually look in more detail in that, subject to certain conditions for public use files. So this is all that I had to share with you today. Thank you so much, Penilla. It's been a great pleasure. Again, just like Neda mentioned, a pity that I cannot be in person with you there, but it's been really a great pleasure to talk to you today. Thank you so much.
Thank you so much, Frederico. I'm so pleased that you could make time for us and participate in this way. And maybe we could have the pleasure to meet you in person next year when you have this flagship report. Let's see.
I would love to. Yeah. It would be my pleasure. Thank you so much.
Thank you so much, both of you. And see you soon. Bye. Nu så ska vi göra en kollektiv ansträngning här. Och nu krävs det någonting från oss allihopa. It certainly demands something of us all from this minute and 5 minutes on. Because now we're going to parallel seminars or breakout sessions. So those of you who like to listen to a seminar in English, you're staying here. And for you who like to listen to a seminar in Swedish, you just crossed the hall to hela världen. The whole world, it says in as a name for the room, and I think that's a very proper name for these days. Så alla ni som nu vill lyssna på ett seminarium på svenska, så ber jag er att gå tvärs över hallen här till lokalen Hela världen. Och ni som vill lyssna på engelska, ni stannar här. Och även följande parallella seminarier så är alltid engelska här och svenska där. Så nu startar nästa om 4 minuter helt enkelt. Välkomna. Och som sagt, ni som vill lyssna på engelska, ni är kvar här. Välkomna.